I hope everybody's doing good. Y'all's exam is Wednesday. Make sure y'all are doing lots of questions and stuff like that. So the plan is we'll go through the rest of your lectures. We may actually cover a few things that y'all are going to go through. Do y'all have lecture Monday and Tuesday? Hey, dog. No lectures. Y'all are done with lectures. Okay, sweet. So we're going to cover everything then. And that's the plan. All right, cool.
Alexis, you have to introduce your dog.
Who is this?
This is Lola.
Oh, she's ready.
She likes coming to class all the time.
Nice. That makes one of us. All right. Let me share my screen. We will do our housekeeping stuff. Remember, if you're looking for the videos, go to the About section on the Scrubs page, bookmark this, and it'll bring you to the videos. They're private. So if you use the bookmark link, you can access everything we've done. You won't be able to search it or anything. And as always, this isn't affiliated with IEA, but if you do not follow IEA on Instagram, you should. Once August starts, we're gonna do a bunch of facts of the day, questions of the day. You'll be able to reach out for tutoring if you need. And those of you that get a 90 or above will be able to join, and there's lots of fun stuff we're gonna do. All right, let's get started. I'm on Scrubs. These slides are there. You can go download them. Lindsey's on Dog Mom. We put a bunch of stuff up there. Do the extra questions. That was the thing. Once you move from MSK to cardio, there were a lot less questions available. So you want to be able to, it's not just buzzwords. You want to be able to wrap your head around the concepts when they start talking about different parameters and stuff. All right, so this is not as long as the previous one. So just quickly, we'll talk about a few things. Mr. Ass. It's not me, I promise. And what was the other one? Miss Ard. I think that's right. Okay, so this was the little way of remembering the different murmurs, right? So during systole, that's ejection, right? You will have either a mitral regurgitation or aortic stenosis, right? Meaning during ejection, the aortic valve is supposed to be open. So if you hear a murmur, it will be stenosis, a narrowed valve, calcification or whatever. Or you can get mitral regurgitation, meaning the mitral valve is supposed to be closed and the blood is regurgitating backwards through it. Okay, the other one is during diastole. That means during the filling phase. Okay, meaning the mitral valve, filling of the ventricle. So the mitral valve would be supposed to be open. The murmur would be a stenosis. The aortic valve is supposed to be closed, so blood would be regurgitating through. Now, the two that are most often tested, aortic stenosis, what do you know about that? What are the buzzwords you could think of? Remember that crescendo, decrescendo, if you listen to it, that whoosh, whoosh, right? And also age. Age is important here. This tends to happen, age-related calcification. So old people, okay? So they like to test about that. 70-year-old patient comes in, new onset, heart issues, I don't know, he's hypotensive. Whatever's going on, think aortic stenosis. The other one they like is mitral stenosis. A lot of times this is sequelae of rheumatic fever. You develop antibodies to it, so you can get that. So this, what you want to remember is this opening snap. And what that means is the valve is stenosed. So it's supposed to open and it kind of opens and then blood starts pushing through it and then it snaps all the way open, right? So you get this opening snap. So this is rheumatic heart disease or rheumatic heart failure, just in case. Younger kids, it can happen. All right, take a snapshot of this. I'm gonna erase it and do something else. Cool, good, great. All right. What else? Okay, let's look at the Guyton cross plot real quick. So remember, the thought process here is that you're gonna have two graphs something like, I forget how the other one exactly goes. Something like this, right? Something like that. Oh, sorry, you know, it actually does like this curve thing, right? Something like that. Okay, so this is our vascular function curve. So we're worried about venous return, right? So that's our vascular function curve. And then we have our cardiac output curve. So we're worried about ejection. So the first thing, we know that this is normal if we have no deficiency. So we'll be at +2. That's good, right? This is our right atrial pressure. We'll be at +2. So the first thing you want to notice when this happens, so normalcy here. So the first thing, if we have a problem, you want to find where is the problem? Where is the problem? So let's say patient is hypotensive. All right, so we're not getting a lot of venous return. So your first question is, which graph are you affecting, the filling or the ejection? Well, if you have less blood, you're affecting the filling, okay? So it's something like this. Now, so here we could say, patient comes in, some sort of trauma, lost blood, less venous return, less filling. So that's the vascular function curve is the problem. The second thing you want to ask, you want to find the decompensation phase, right? Meaning, when we look at this graph, we see that this has changed, and you could tell it hasn't compensated yet because the graph is still on the original cardiac output. Once it compensates, then the point will change off of this. Okay, so let's do this. 3 will be the compensated phase. Okay, now at that point, you know, by compensating, if you have less blood getting back to the heart from the right side, the left side of the heart has to contract harder. So we would expect a greater contractility. Okay, so you see, because we have a decreased venous return from the right side, we have to have an increased cardiac output for the left. We have to maintain blood flow. So the third point is this compensated phase. So you could find the compensated phase because it's at 2 new points. One is the decompensated portion, decreased venous return, and one is the compensated portion, the increased cardiac output. So this is how we maintain blood flow in a state of decreased blood. Decreased blood have to increase the contraction. That lower amount of blood volume you have to contract the heart harder to get it around. Now remember, there is a consequence to doing this, and look how we've changed, let's be like +1. Look how we changed our equilibrium, right? All right, and then, so we could have it opposite. Let's see, I should probably do a new graph. We could have it opposite in that, let's take cardiac output, venous return. This is our equilibrium. Now let's say we have some sort of heart failure, all right? So this is our normal. We have heart failure, so we're decreasing our cardiac output. So 1, where's the problem? The problem has decreased cardiac output. You're in heart failure, right? Older people, congestive heart failure, that can happen. What point is this? Has it changed off of the original vascular function curve? No, right? This is our original one. So we haven't compensated yet. So this is the decompensated point. And then how do you compensate for decreased ability to contract? You increase the amount of blood back to the heart, to the other side. So our vascular function curve has to come up here, something like that, right? So we're at 2 new points. So 3 is going to be our compensated phase. Meaning, because we had heart failure, because we have decreased cardiac output, we have to have an increased venous return, all right, to keep the blood volume constant. So like I said last time, they're like a couple, right heart, left heart are like a couple. They work together to achieve the same goal. They have different jobs, right? So the left heart is going to deal with contraction and pumping blood The right heart is more of a filling aspect. All right, good. And then lastly, okay, let's do the EKGs now that y'all have had time to kind of look at these. So you should be able to do the, like, imagine this graph in your head. And remember, on the exam, since you don't have scratch paper, they're going to make this easy. At least they did for all of us. So if we did like this, remember, all the way to your right is your lead one. Right, so facing down is F for foot. Now let's do these leads. So between 1 and 2, there's 60 degrees, right? So this would be 2. And then from 2 to 3 is another 60 degrees. Now, the important point is these are the positive aspects. So these are all of the heads of the graph. I should have kept going, but so this is the negative tail of 3. This is the negative tail of 2. And then when you want to add the other ones, remember you're looking at the patient. So AVR will be over here, R for right arm to the patient, and AVL will be over here. Now, the important, sorry, we need to make these the positive points. Remember, for these leads, wherever you're pointing to is where the positive pole is. So right arm positive, left arm positive, foot positive. And then for the, those are the limb leads, and for the precordial leads, 1, 2, and 3 are all going to be pointing in these directions. The point is you want to be able to picture it in your head. So let's say they give us one graph, something like this. So we have a +6. Let's say this is lead 1. And then I do believe on the exam that they will give you perpendicular leads, just because those are easier to do in your head. And so let's say they also give you AVF, and so if we did calculate this out, let's say it was sorry, +6 and -2, right? So those are additive. So 6 minus 2 is 4. So we know we're at a +4. So if we use the tick marks, 2, 3, 4, we're around here. Point being, you know, you're on the positive side of 1. So if you look at AVF, and we had +2 and -1, again, they're additive. So we have a total of +1. So you could see that we definitely land in this quadrant here, right? The point is, though, if you're thinking about it in your head, you should be able to say, okay, if 1 is positive and AVF is positive, you're going to land in this normal range over here, which this is considered normal. Anything up to -30 is technically now considered normal. That does make it a little complicated because it's not exact. So, but anything from -30 to 90, let me do a different color, is considered left axis deviation. And then anything from 90 to 180 is considered right axis deviation. Right. So let's try this. Snapshot if you don't want to take a picture of that. Now, let's say we're taking the test, right? So this is what's going to happen. They'll give you, well, let's do this. In lead 1, they'll give you, say, a +2 -4. So +2. So remember, we're counting the deflections off of the normal axis. So a say 2 little boxes up, and say -6 boxes down. Okay. So you come out with, in lead 1, a -4 deflection. Okay. So in the equation, in the stem of the question, they'll either give you some sort of image like this, or they'll tell you the deflection. And then they'll also say in AVF, we have a, say, +2 -1. So you add those together, 2 -1 is 1. So we had a +1. So you should be able to sit down in your head and say, what quadrant does that fall in? Okay. Point being, one, we remember our axis, so one has to be over, like if we did this, since it's -1, that area, it has to be on this side of the graph, right? And then AVF is in the positive direction. So it has to be here. So you know immediately that you are in this quadrant, right? Because -4, 1, 2, 3, 4, right? So we know that the positive deflection of lead 1 goes this way. So since this is -4, we're on this side, AVL, I didn't really draw this well to scale, would be like here, so it'd be more like this. Anyway, point being, you're in this area of right axis deviation. That is as hard as I think they'll make it for you. So positive, negative, figure it out. All right, cool. Is everybody good with that? And we'll move on to the new stuff. Any questions?
Do
All
you
right.
think that, oh,
Yeah, go
sorry.
Yeah.
Do you think that they'll pretty much just stick to like the left axis deviation, right axis deviation, and just maybe ask us like what would be wrong?
Yeah, for sure. Yeah, and then so if there's left axis deviation, it's usually left ventricular hypertrophy. That's usually classic hypertension will cause that. And the right axis deviation is usually a filling problem. So right ventricular hypertrophy. That's probably as far as they'll go. So right goes with right, left goes with left. I don't know if I've ever heard anything that's extreme axis. I don't know. I don't even know how you get that. You probably won't live very long. So.
And remember, guys, this stuff is going to be maybe like 1, 2, 3 questions on the exam. Understand it the best you can, do the best you can. But if it gets down to the wire and you're choosing what to cram right before, it's not EKG stuff. So.
Yeah, in regards to filling out the mean electrode axis, you will have some questions on this disorders, but you go into more detail in term 4, but it is important to kind of understand this. So there are different reasons you can get arrhythmias. So problems in the rate of the heart, it's not a constant rate. So whether it's the automaticity, so the nodal firing, or the conduction through the conduction pathways, it could be a problem. A lot of times it originates in the first part, the sinoatrial node. So that is supposed to control your normal rhythm. So if you have some sort of erratic beat there, you can get an arrhythmia, or you can have problems somewhere else at the AV node. Sometimes it'll fire on its own, and you'll get different waves, like a different atrial contraction from ventricular. And you could see that on the EKG because the P waves and the QRS waves don't correlate. You could also get sometimes there's called this Wolff-Parkinson-White, where like this syndrome, this is like this extra pathway that goes to the other side. And so it does its own thing. So it makes it all messed up. Y'all may have come across that. So look, if we're looking at just tachycardia, right? Do y'all remember the little trick? I think I actually have it coming up. So first, we want to look at our R peaks, right? So the QRS wave. If we're looking at this, remember the P wave comes right before the QRS, and then the T wave, P, QRS, T, P, QRS, T, right? So we could say that this is a normal rhythm. Remember, rhythm is like the dance moves, right? You have a normal rhythm. This is what you would expect for the dance moves of the beats, right? This is how it should work. Now, your rate is also important. The rate's going to be, are they constant? Are these R waves constant throughout, right? So if you looked at the different boxes, do they come fairly close to each other? You could say, yeah, like this looks like a normal rate and rhythm. Now, if you did calculate it out, and I use that trick, 300, 150, 100, 75, 60, 50 for the big boxes. So we go from the first R peak, we go 300, 150, 100. So you say about 125. So yeah, that's tachycardia. The beats are too fast. Now it's a normal rate and normal rhythm, meaning the rhythm looks normal. You have that constant PQRS, and the rate is constant. Even though it's fast, it's still constant, okay? So anything over 100, your normal heart rate should be 60 to 100. This dude's at like 125, right? So you could say sinus tachycardia. Now, if you have atrial fibrillation, you have this irregular R to R intervals. So can you say the rhythm is normal? Well, it looks fairly normal, at least here, right? So we have P, QRS, T. but you could see here that it doesn't, it's obviously not normal. So you could say this is irregularly irregular. Not only is the rate different, look at these R to R peaks. This is much different. So our rate is off. So your beat's going to be off. It's going to boop, 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 boop. You know, it's not constant. And also the rate's off, and then also the rhythm's off, right? Because you would expect the PQRST in this section here, but you don't have it. And this looks funky too. This looks very funky. So you could say atrial fibrillation, the P waves aren't distinguishable. You can't really appreciate them. I mean, you can kind of see it there, but it's not really discernible here. So you can't technically find them in this area. So if there's no detectable P waves, remember the P wave correlates to the atria. So if there's no P waves, there's some sort of problem with the atria. So basically, for this atrial fibrillation, the SA node's firing and the atria is just kind of shaking like this. And then the ventricle, the AV node kind of picks up the pulse or picks up the conduction, and it contracts normally. But for whatever reason, the atria is not conducting properly. So that's an irregular pattern. So you have an irregular pattern plus the irregular complex, right? Okay. Ventricular arrhythmias can happen too, whether it be tachycardia, very similar to the atrial fibrillation, so the atrial arrhythmias, but these can happen too. And there's some drugs that you would give specifically for it, but y'all would get to that in term 4. So look at this. Is this a normal rhythm? Is this the normal dance moves of our PQRST? No, right? You don't see a P wave. You don't see that classic QRS. You don't see the T. But you could say the rate's normal, right? These look pretty constant throughout. So you have a normal rate, but an abnormal rhythm. And because the way this works is you can be deadly. You have to shock the patient to try to get them back into a normal rhythm. The problem is when it does this, you don't have enough time to fill the ventricles, right? The ventricles basically contracting so fast that you don't have time to fill it, so you're not pumping blood throughout the body. So again, the point being, if you got this on the test, you could say these are constant. Even though they look funky, there's a constant rate between them. It's just not a constant rhythm. The dance moves aren't right. All right, so regular pattern, but weird complexes, right? And that's the point you want to get across. Now, ventricular fibrillation. Now, so that the last one was tachycardia, right? So it's just beating too fast. It won't let the ventricle fill. This fibrillation is basically just shaking. So the ventricle is just shaking. There's literally no blood flow. So you have to defibrillate the patient and hopefully get them back into a normal rhythm. But you could see here, this is completely erratic. The dance moves, the rhythm's off, and the rate, I don't even know how you would even calculate this rate. There's not even any really discernible R wave. So this is very bad, irregular. So yeah, all these waves are fibrillary waves. So yeah, now what they do like to test on is these, because these are very easily noticed on the test. So first degree heart block, you can see here, these PR intervals are elongated. They usually don't test on this one, but I'll show you what they do in a second. But you could see, they didn't ask us this, but Kishore had mentioned previously that they do one shot to know. Dr. Toledo had mentioned to his class that they did one shot to know the proper length between the PQR and that the PR interval, right? Between the P wave and the QRS wave. So first degree heart block means you have a longer distance between the P wave and the QRS complex, meaning for whatever reason, the conduction from the atria to the ventricle is taking too long, right? So it should be a quick PQRS, like within the first 0.2 seconds, but for whatever reason, there's a P, kind of stops for a second, and then the QRS. So, and if you count the boxes, you could say that this is elongated, okay? Now, this is one of the ones they like to test about. So Mobitz type 1, also called Weckenbach, y'all will probably hear it as Mobitz type 1 though. You get progressive lengthening of the PR interval, okay? So there's a progressive distance from the P wave to the QRS. Look how it gets longer. So we have P, QRS, T. Look at this P, it's longer, right? Between this one and this one. And then this one's even longer till eventually you get a dropped wave. So the reason they like to test on this is they could put this strip on the test and you'd be able to identify that there's a PQRS. Why is this P further away from this QRS? Okay, I see this piece even further from this QRS. Okay, I see this piece here, and there's no QRS. Progressive lengthening is a Mobitz type 1. Okay, and this is typically an AV nodal problem. It gets longer, and this delay gets longer and longer until you eventually drop the wave. So progressive lengthening is type 1, or they could give you a Mobitz type 2. So you could see this one doesn't give you, so the point of the type 1 is that you kind of get a warning. It gets a progressively longer, and you know as it gets longer, it's about to drop the beat. But the Mobitz, sorry, I'm a nerd. Mobitz type 2, you don't get the warning, right? So it's a PQRS, and then all of a sudden you just drop a beat. So if you were trying to determine, is it Mobitz type 1 or Mobitz type 2, you would try to see if you get progressive lengthening between the P and the QRS wave, okay? If you get that progressive lengthening, it's type 1. If you look at this strip and you say, where's this QRS? Okay, it may be a Mobitz 1 or Mobitz type 2. Let me check this PR interval. They look pretty constant, but we keep dropping it, dropping the wave. So therefore, if there's no progressive lengthening, if you don't get that warning, then it's a type 2. Now, Mobitz type, or sorry, it's not a type, it's just called a third degree block. This one's really bad. There's no correlation between the atria and the ventricle contracting. There's no correlation between the P and the QRS. They do their own thing, okay? So if you were to look at this, you would say that there's just no patterning. But on the exam, I think the one they gave us was either one of these, Mobitz 1 and Mobitz type 2. Just because some of these get funky and it's more complicated than we need to get into. But it is pretty easy to determine if you get progressive lengthening between dropping a QRS in the type 1, or you just get a PQRS and then a drop without the lengthening, type 2. And again, type 3, there's no correlation. They're doing their own thing. And obviously that's a problem because you need the atria to fill, the atria to contract a little bit, the ventricle to fill, and then the ventricle to contract to get blood flow. So if they're doing their own thing, you know, you're just not getting proper blood flow. You have to put this patient on a pacemaker, right? Surgery. Okay, and I think this was what Lindsey was referring to last time, that little poem thing, or I don't know. This has the different ones. Just remember Weckenbach is type 1. Go search, I think NYU did a Weckenbach. I'm bringing Weckenbach, Justin Timberlake. I'm bringing sexy back. Yeah, it was Weckenbach. It's very funny. You'll never forget it. Okay, anyway.
Hey, Brady, I have a question.
Yeah.
Real quick. So on all the practice like EKGs that we've seen, they've had like a little indicators of P, and like you can see right here, it says like the P's above it. Are we going to get that or no? I figure we're not going to get it, right?
I wouldn't bank on it. No.
Yeah, that's what
you should be able to. Yeah, you should.
All of them have it, and it's like I can see them and I recognize them, but I just wanted to be like, all my questions that I've had have had it on there for some reason. So just wanted to make sure.
Yeah, I definitely wouldn't bank on that. I mean, maybe if it's like crazy erratic, they would do it, but I definitely wouldn't bank on it. Okay, as for bundle branch blocks, that's lower down in the conduction system. Really the only thing you need to know about this is you need to be able to identify. So remember, when the branching pattern goes down, some of it's going to go to the right heart, some of it's going to go to the left heart. If you get a block in these bundles of His, these lower down, you get different characteristics. So just make sure you can identify these. If you get a right bundle branch block, it looks like bunny ears. Okay, so be able to identify this as soon as you see this. You know, right bundle branch block. This one, left bundle branch blocks, looks like a cowboy hat. Okay, so if you see that, this wide QRS, what does that mean, a wide QRS? It means there is a prolongation of the ventricle contracting, right? You're widening out the ventricular contraction for whatever reason. And that's because you have a block going down the conduction pathway. So if you have this wide QRS, right's bunny ears, left is cowboy hat, easy points. All right, let's move on to some of the blood stuff. And I want you to know that this stuff does get a little complicated, but Dr. Ampadya, who taught us, I hope she taught y'all too, she's great. the lab values for these are going to be what's most important. Clinically, they're going to give you lab values and you need to know what's going on. So y'all try this one and y'all could private message Lindsey and I. All right, very good. Okay, so elevated PT, right? Also known clinically as INR, International Ratio, something like that. So if you see that, that's PT, and normal APTT. So prothrombin time is going to correlate to your extrinsic pathway. APTT is going to be intrinsic pathway, right? What would be elevated in hemophilia? What of these? A is factor 8. How do I do 8? Yeah, 5 and then 3. Yeah, 8. Yeah, APTT, good. What about, okay, we could do these separately. What about, let's do C. What about C or E? What will be elevated? It's not here, but these are early in the pathway, right? Yeah, but yeah, bleeding time, right? So, right. So the problem is with that GP2BA thing. But when you're looking at lab values, remember these two. Well, I don't want to confuse y'all. Both of these, this one and this one, correlate to that initial platelet plug. Okay, so if you can't form the platelet plug, originally, you're going to get increased bleeding time. Right, that would make sense, right? Because that platelet plug is going to stop that initial bleed. So if you have a problem there, you get increased bleeding time. Now, one of the tricky ones, and they like to test on, what about von Willebrand's disease? Also platelet plug problem. So you're going to get increased bleeding time. But it does this funky thing, I think with factor 8. Somebody can correct me if I'm wrong. I believe it's factor 8, where it like activates factor 8. So if you have that, you'll get not only an increased bleeding time, but since factor 8's on, yeah, it is factor 8. Okay, good. APTT. I think I have a slide, but yeah. So if you see this, which is a weird thing, it's like, why do I have a problem forming the platelet plug and a problem with the coagulation cascade? Like, that's not good, right? Like one or the other, like pick. But yeah, this is because von Willebrand's disease not only affects that platelet plug formation, but will also affect that cascade. Cool. So yeah, so that's how you want to look at those when you do these. Yeah, thank you. Awesome. Okay, so you can highlight the slide or put a star on it. The way, I think, I don't know if I have the actual pathway. So y'all have looked at these pathways. I think the way I try to remember it is people are intrinsically complicated, right, on the inside. Extrinsically, maybe not so much. Intrinsically, you know, they're more complicated. So the intrinsic pathway has more factors involved in it, right? So we have all these different factors, and you can also look at anything in red here is the common pathway. So remember, the extrinsic pathway primarily deals with factor 7. Okay, that's the big dog over there, and it's fairly easy, right? We're just really worried about 7, and then from there you go to the common pathway. Okay, whereas intrinsic, remember I said people are intrinsically difficult. You could even take that a step further and like versus PT. APTT has more letters in it, so it's more difficult, right? So we have all these factors involved, and then, sorry, I shouldn't do it like that. So we have all these factors involved, and then we come to the common pathway. So what actually happens is extrinsic and intrinsic come together, and they both form this common pathway, right? At factor 5, and then 10, and then you go down to everybody's favorite, factor 2, which is thrombin, to fibrin. fibrinogen. Okay, so the point is you need to be aware of is that if you have a problem with PT, it's usually factor 7, but it can also be a problem with the common pathway, right? It's not just limited to the extrinsic pathway, because if you have a problem with these factors downstream, it could be considered that as well. Okay, and intrinsic would be one of the more one of these factors, but can also be a problem with the common pathway. Now, I don't think they would give you a question where it was a problem in the common pathway, because it complicates things. It's like, well, it still doesn't tell you exactly where the problem's coming from. So if it's extrinsic, it'll probably be factor 7. If it's intrinsic, it'll probably be one of the hemophilias here that you're looking at. So that's usually how it goes. So keep those in mind, because this will be tested. They like to test this. This is common in the population. So also hemophilia, one of the buzzwords, they get bleeding into their joints. Okay, if they ever talk about that, that's usually hemophilia. They get big swollen joints. Okay, yeah, this is more genetics. We're moving on to this. So try this one and we'll go through this after. All right, so this is how this works. This is this interesting process that, so first off, we know that post-translational modification is the thing we've learned in undergrad. It's the things y'all talked about already. That's like when you put the 5' cap and the poly A tail. This is after you've transcribed the mRNA, you've transcribed the mRNA, you have that transcript, and then you post-translationally modify it. You add the groups on the ends. This is this interesting process where it's actually after transcription that you actually can modify it. So this is the thought process. You actually, so I believe in the liver, you use ApoB100. Now, in the gut, you actually use ApoB48. So instead of the gut transcribing its own mRNA to make this ApoB48, it's much more efficient to have this ApoB100 and then just cut it, right? They basically cut it in half, and half of it is used here. So it's an efficient way for the body to make this product, opposed to just having to transcribe the exact same thing again. You already have this ApoB100, just cleave it in the middle, and then you could use that part. So it's just it's a good, efficient way of modifying things. It's interesting, and remember, it's this post-transcriptional editing. Okay, so depending on where is C not correct? Chylomicrons in the blood. I'm not exactly sure. Probably not chylomicrons, because those are the larger of the structures. I think ApoB48 comes in a little later. So
I think,
yeah.
I was going to say, I think the B48 releases it into the lymph, not the
Great.
capillary.
Okay, that makes sense. Thank you so much. So yeah, this will go into the lymph, not the blood. Okay, and that's important, right, to clear it out of circulation. Good. But the point here is that it's after transcription. If it was translation, that's when we talk about the 5' cap, poly A tail, all that nonsense. Good nonsense. All right. Right. So here we go. So ApoB100 in the liver, ApoB48 here. So just cleave it. And the process of doing this post-transcriptional editing, there are 2 ways we talk about. One is switching a C to a U. Remember, you are away, right? That's a stop codon. You are gone. You are away. You go away. Yeah. So those are all stop codons. You change the C to a U in the intestine, cleave it in the middle, right? It forms a premature stop codon. And by doing this, you're taking the C, so cytidine deaminase. By deaminating the cytidine, you turn into a uracil. So by doing that, you can cleave it, okay? So they can ask you that. They can ask you this process of forming ApoB48, what is the enzyme involved? Cytidine deaminase, the process of changing a cytidine to a uracil, making that stop codon, right? So yeah, it's pretty interesting. Who knows how that happened evolutionarily? Who knows? All right, yeah. And then there's the other one. I don't know if I have a question on it. Do y'all remember the other one? Happens in the brain. I think it's like an A to an I. Is that right? Adenosine deaminase. I believe it's adenosine deaminase, and it helps to regulate the brain, like the calcium, the chloride or calcium flux in the brain. But maybe check your notes just in case they ask that. But this is the one that's usually tested. All right, let's try this one. Right, love questions like this because they'll give you something like this and it's a giveaway. So somebody could shout out what this is.
Tanger's disease.
Tangiers, yeah, right. Yeah, Tangiers. Tangerine tonsils, Tangiers, oranges, great. So yeah, again, this is problem with ABC transporter. So we have this lecithin cholesterol acetyltransferase. You may see it abbreviated as LCAT, LCAT. Okay, so these will be straightforward on the test and maybe show you a picture of them. So yeah, and you can see this. This is this ABC cholesterol transporter. I think this is the first time y'all are talking about these ABC transporters. Sometimes in the liver, you get a problem with this, but y'all will get to that. Dubin Johnson, I don't think y'all talked about that. Anyway, so LCAT, ABC cholesterol transporter, Tanger's disease, orange tonsils. Good. Okay, this is obviously Dr. Trotz. She loves this stuff. So cardiovascular problems. Which one? ABC. Is ABC in cystic fibrosis the CFTR gene? Is it an ABC transporter? I think you're right. Yeah, that would be right. Yeah. Or is it? I'll look it up in a second. It's a type of ABC transporter, but it's specialized. Okay. Yeah. ATPase binding cassette. That's what it is. Yeah. That's it. Right. Okay. Thank you. So it basically, the idea of that, the ABC binding cassette, is that it uses ATP, but it's not active transport. It doesn't use ATP to help molecules cross against their gradient. It uses ATP just to open the channel. So it's still passive diffusion, but it uses ATP to open the channel. So once the ATP is used and the channel's open, everything goes down its concentration gradient. Yeah, that's the idea there. But I think Dubin Johnson is like this black liver thing that y'all will get to that directly uses this ABC transporter. Okay, anyway, if that's, y'all haven't heard of that, then don't worry about it. Yeah, so anytime you increase triacylglycerols, that's bad. Remember, HDLs are good, tags are bad, and HDLs are good and LDLs are bad. LDL is bad cholesterol, HDL is good cholesterol. There are medications that decrease your LDL, increase your HDL, but tags are basically fat in the blood. So anytime you have tags and you have high LDL, you tend to put deposits down into the blood vessels of cholesterol, and you get these plaques. So waist to hip ratio less than 1, that's a good thing. BMI of 24 is a good thing. Visceral fat tends to be worse than subcutaneous fat. Visceral meaning fat around the organs. It's really confined, and so that tends to be worse. And like I said, high HDL, that's a good thing. All right, and then these are kind of common sense risk factors for metabolic syndrome. When you think of metabolic syndrome, you're thinking of problems with insulin, or you're thinking about diabetes, stuff like that. So this all kind of goes together. This this constellation of symptoms that really does lead to diabetes. So you kind of put these all together. Risk factors for diabetes, metabolic syndrome goes with that. All right. Oops, gave you the answer. Quick fire. So I kind of gave it to you, but remember, prostacyclin, this is prostacyclin. These are breakdown from prostaglandins. The way I like to remember these is that prostacyclin and thromboxane are basically opposites. All right, so prostacyclins are going to cause, inhibit platelet aggregation, and they're going to cause vasodilation. Plus vasodilation. Whereas thromboxane is going to cause platelet aggregation and vasoconstriction. Okay, so I think of them as opposites of each other. Y'all will get into this much more detail when y'all start talking about the NSAIDs, aspirin, ibuprofen, all that stuff. But this is a good little thing to know. I would make sure to know this. Primarily, thromboxane is used in platelets. So if you use low-dose aspirin, you're dealing with thromboxane in the platelets, and then high-dose aspirin will help more with inflammation. So that's why people that have cardiovascular problems, they put them on low-dose aspirin. And that's just going to help prevent these platelets from forming because you're inhibiting thromboxane. Okay, so if you take low-dose aspirin, okay, I think it's like 61 milligrams, something like that. You're going to inhibit this, so you inhibit platelet aggregation. So less chance of forming blood clots, less chance of forming, having a myocardial infarction, right? Once you get to higher doses of aspirin and ibuprofen and stuff, then you start dealing with inflammatory problems, or like decreasing inflammation. And you can see prostacyclin here works on the endothelium. Okay, inhibits platelet aggregation, vasodilation. Yeah, and you could kind of see the pathways here. So that may be good to know how it works. Just because they're so, these are over-the-counter medications that they tend to use. So, okay. They really don't give you not questions on the exam, but let's go with this. Yeah, they're COX blockers. Aspirin is a COX 1 and 2 blocker. Some are more specific, but it blocks them both. Whoops. Yeah, right. So nitric oxide, it doesn't, okay, so this is a tricky question too, because it doesn't actually mediate the permeability of the vasculature, meaning it doesn't, these are going to be, the rest of them are going to be released so that holes will form in the vasculature. So all of the inflammatory mediators, your immune system can go out of the blood into the site of infection, right? Nitric oxide is just going to do vasodilation. Okay, so when you actually, so all of these are kind of released together, but these are going to help to put pores or increase the permeability of the vasculature so you can get molecules like the immune system out of circulation to the injury site. But nitric oxide is going to deal with vasodilation, okay? And Lindsey's going to talk about shock a little later. And when she talks about that, some of the things like nitric oxide or histamine even can cause chronic vasodilation. So yeah, and histamine, for example, will do vascular permeability, but it also increases, it also causes vasodilation, but nitric oxide is the only one that causes vasodilation without vascular permeability. This is why when you have some sort of allergic reaction or, on your skin, it turns red, right? Because the histamine is released and you get increased vascular permeability and vasodilation, okay? So just keep these separate. And here's a nice little graph to help you regulate it, help you learn it. But some of these y'all are going to talk about in term 3. All right, let's try this one. Yeah, this is a classic question. Primaquine for malaria prophylaxis. Somebody tell me what he's got first. So always when you do these questions, obviously the first rule is to diagnose the patient. So what's he got?
G6PD deficiency.
Yeah, G6PD. PD deficiency. Okay, so these patients tend to be okay until there's some sort of insult. Primaquine is a sulfa drug. So some people have sulfa allergies. These sulfa, components of the medication tend to be really toxic, but they need to use them for some medications. So if people are really sensitive to medications, fava beans, that's a good example. That'll cause G6PD problems. Anyway, so this is a pretty strong medication to help with malaria prophylaxis for people that are traveling to endemic regions. But this primaquine has this sulfa reaction. So people that have this deficiency, this G6PD deficiency, can't cope with the sulfa component. So some of these stronger medications, you can also see this in these patients, these G6PD patients, when they get sick. Okay, so if they have a lot of inflammation built up, these glutathione molecules help to work with hydrogen peroxide and better yet, the reactive oxygen species, those ROS species. Okay, so it helps to break down products that are floating around in circulation. So if you can't do that, this tends to cause hemolysis, right? Lysing of the red blood cells. They may not even tell you in the question, the patient has hemolysis. They may say he's going to be traveling to Africa. He was given a medication and now he has darkened urine. Darkened urine, blood in the urine. What is he taking? Primaquine, probably has G6PD deficiency. Okay, so if you can't reduce this, jaundice could be there. If you have a prehepatic jaundice. So sometimes hemolysis can, if it's bad enough, it causes increase in bilirubin and it'll cause a prehepatic jaundice. Yeah, we'll get into jaundice. There's different types of jaundice and stuff, but yeah, that's a good way of thinking about it. Anytime you're lysing a lot of red blood cells, that bilirubin can start floating around and turn you yellow, which is jaundice. All right, and this is this pathway, right? So these reactive oxygen species come in, you use hydrogen peroxide and you just break them down, right? You oxidize them, and you need to use glutathione peroxidase, right? To help regulate this hydrogen peroxide. You don't just want hydrogen peroxide floating around, wherever it wants. You want to be able to regulate it. So you need to use it to break down these products or these medications or these, when you get sick, all of these inflammatory mediators or the bacteria. So you need to be able to do this, and then you need to be able to reduce it back after it's been oxidized. So once you oxidize it, right, once you break down the hydrogen peroxide, if you can't reduce it back, then you're going to run out of it, right? So glutathione reductase is there. And so this is the problem. You can't get this reduced form to use it again. So you run out. And Lindsey's going to talk about the pentose phosphate shunt in a little while too. All right, so another buzzword. What causes this? Oops, option C, sorry, let me go back. Let me go back real quick. So it's not the oxidized glutathione. If you look in this pathway, you are able to break down the hydrogen peroxide. You will get oxidized glutathione. The problem is you can't reduce it back because of this. You don't have G6PD. Glucose 6-phosphate dehydrogenase, which helps with this process of reducing it back. Yeah, it's the reduction. That's the problem, getting it back to the normal form. Okay, so chronic granulomatous disease. What does that mean? You form a lot of granulomas, right? Granulomas tend to be, you see those in like tuberculosis, stuff like that. It basically means you have some sort of infection and you've walled it off. You can't kill it, so you make a granuloma. You make this big shell around it. This tends to happen in tuberculosis with normal people because it's hard to kill tuberculosis. So the best the immune system can do is just wall it off and hope for the best. So when you get older and this granuloma breaks down, you tend to get reactivated tuberculosis. But the point is, Why are you forming these chronic granulomas? Because you can't properly kill the bacteria. If you can't kill it, the best you could do is wall it off. So NADPH oxidase is the specific enzyme involved in chronic granulomatous disease. So yeah, so NADPH oxidase here, you can see, so you're not able to compensate for those reactive oxygen species, okay? Using too much oxygen, you don't get this respiratory burst. That respiratory burst is what actually will kill the bacteria. So if you can't kill the bacteria, you tend to make these granulomas. You try to wall them off. So yeah, so the other one, the next step down is you can also get a myeloperoxidase. So I want you to know this, myeloperoxidase deficiency tends to be involved with fungal infections. They could definitely ask that. So would you get a normal respiratory burst? Yeah, sure, because NADPH oxidase is fine. So you'll get that respiratory burst. That's a good thing. You don't have chronic granulomatous disease, but you won't be able to form hydroxychloride. And so by not being able to form this hydroxychloride, myeloperoxidase is what forms the hydroxychloride. Okay, so if you can't form that, you're going to get increased fungal infection. So keep these all together. Remember, normal respiratory burst because this is intact. Okay. Okay. Yeah. Yeah, so clinically superoxide dismutase, yeah, you'll get similar problems because again, you're trying to get this respiratory burst, you're trying to kill the bacteria the best way you can. Hydrogen peroxide is a good way to go if you can deal with it. But those superoxides are those O negative, right? They're charged. So by having them charged like that, they can actually kill. So you have to deal with that. Yeah, so those are good things to know. Easy points on the test. All right, here's good. So we're talking about pallor, right? So somebody had mentioned jaundice, but what if the patient is like pale, right? Being pale usually relates to decreased blood, right? Or hypovolemia, right? Pale, maybe iron deficiency. So taking a sulfa drug, what do we talk? Sulfa drugs such as Primaquine, right? For malaria, that's the one they like to use. So yeah, so again, let me look at this. Talking about G6PD, glucose 6-phosphate dehydrogenase. Okay. They really like to test these. You can see here, yeah, look at the jaundice. This is scleroicterus, which is basically jaundice of the sclera of the eye. Sulfa, right? Sulfa drug, sulfamethoxazole is a, I can't remember. Methoxazole, it must be some sort of anti-fungal. Don't quote me on that. So acute hemolysis, anytime acute hemolysis, we're thinking you can get increased bilirubin, so you get jaundice. So this is correlated with G6PD. But just remember, these people tend to be normal. You don't have symptoms unless there's some sort of insult, some sort of medication, new medication there that they're using, or they have some sort of, they're sick for whatever reason. Urine is reddish brown, right? That would be indicative that you have blood in your urine. And G6PD deficiency here, you can see that G6PD deficient, G6PD is using that pentose phosphate pathway. So you need NADPH for that pathway. And if you don't have that, glutathione reductase is impaired, okay? So once the glutathione's oxidized, you need to be able to reduce it back. And if you don't have adequate NADPH, you can't do that. Okay, cool. Another big thing to know about this, another buzzword, is these Heinz bodies that form. So you can see that you can see those in the red blood cells. What ends up happening is you have these little aggregates, these Heinz bodies that form, and then the macrophages will come in. The macrophages kind of big immune system cells that'll come in and kind of attack, and they'll take bites out of this. So you get bite cells as well. So I don't have write that in there, bite cells. So when you break down these insoluble proteins, these Heinz bodies here, usually it's hemoglobin. But if the macrophages come along and take a bite out of them, they're called bite cells to try to get rid of the Heinz bodies. All right. Let's see. Hemostasis. All right, so let's discuss this in a little bit more detail. So the first problem is, if you have some sort of injury, is you need to stop the blood, right? Stop the blood flow, stop the bleeding. So the first thing you want to do, you have this vascular spasm. So the vessel is going to constrict to stop the blood flow to it, vasoconstriction, and then you're going to lay down a platelet plug immediately. And so that's that primary hemostasis. And then we go through that blood coagulation pathway, that secondary hemostasis, where we have all the factors that come in. So the platelet plug will do the initial plug formation. It's not too stable, but it does the job for the time being. Then you have time for the coagulation pathway to come through. And then you could break down the clot and make a scar if needed. All right, so you can see here this vascular spasm, you have this injury here, so you get this reflex vasoconstriction. It's going to cause decreased blood flow in a short term, but until that platelet plug forms and the coagulation cascade comes in, you can't really, this is just have to do. So endothelium will cause vasoconstriction. It's one of the mediators there. So if there's some sort of injury to this layer, this endothelium will help to cause vasoconstriction. And then you form the platelet plug, this primary hemostasis. So we'll talk about some of the problems. Remember, we talked about Bernard-Soulier syndrome, Glanzmann's thrombasthenia, and von Willebrand's factors are the ones you're going to need to know. So any problems with that, you're going to have problems forming the platelet plug. This is from first aid. It kind of walks you through the process. Get that transient vasoconstriction, and you get von Willebrand's factor coming through. And yeah, so you can read that if you want. And this is from Dr. Mpadzi's lecture. So you get these different factors that come in. It's important to know which factors go with which disease. So I think, yeah, this is good. Bernard-Soulier is that GP1B. Von Willebrand's have obviously that factor. And then Glanzmann's is 2B3A. So know which goes with which, but theoretically, if they give you the labs and they just tell you increased bleeding time, you can't really tell between Glanzmann's and Bernard-Soulier, right? You're just going to get increased bleeding time. You don't know why. They have to actually check the factors to see what's up. But for von Willebrand's disease, you'll get the increased bleeding time, but you will also get that increased ABTT, right? Because remember, von Willebrand factor helps to activate factor 8 as well. So important to know the lab test, right? Increased bleeding time because you can't form platelets. Okay, so then once you form the platelet plug and you've efficiently stopped the bleeding, you can form the fibrin clot, the secondary hemostasis. So this process is going through both the extrinsic and intrinsic pathway to eventually form this fibrin thread around it, right? And you can see that here, it's kind of illustrated, kind of forms this clumping pattern to kind of, to coagulate the blood and to make it very dense so that there's no increased blood flow and you can go through the repair process. So extrinsic, remember extrinsic is the easier one. We're mostly dealing with 7. They'll talk about a factor 7 deficiency, immediately it's a problem with the extrinsic pathway. It's a problem with, you'll get increased PT, prothrombin time, or increased INR. They're the same thing. Now you eventually go down to factor 10, which will be the first part of that, of the common pathway. And then, as I said, people are intrinsically difficult or intrinsically more complicated. So it's a more complicated pathway. 12 to 11 to 9, remember you have to skip 10 because 10 goes to the common pathway. So 12, 11, 9, 8, 7's on the other pathway. And then, yeah. So 9 goes to 8, and then you go to the common pathway, which is 10. So you just kind of have to sit with it, maybe whiteboard it once or twice, and make sure mostly just make sure 7 goes with extrinsic, and everything else goes with intrinsic. And then they go down to 10. 10's common, right? Yeah. And you can see the common pathway here. Once you get to 10, you can break down 5, and then 2. 2 is activated. 2 is thrombin, right? So thrombin is very important. There's medications used against that. And then you make, then thrombin, factor 2, can take the fibrinogen, which is not active, cleave it. And then once you cleave fibrinogen, you make fibrin. And that's those fibrin clots that form. Okay? Takes a little while to get through, but once you get it, you get it. And this is the whole thing. Intrinsic, extrinsic, just 7. Everything goes to 10, right? And everything goes down from there to thrombin. And then, so we're going to talk about thrombin in a second. It's a little bit more complicated. This is from first aid. It does kind of show everything. I like it because it shows everything, but it is kind of complicated. So, but just take your time and sit with it, and it takes, and eventually you'll get it. So yeah, the thing about thrombin, factor 2, is it's critical for a lot of factors, and you can see that here. It's critical in activating factor 1, which is your fibrin, the actual threads, factor 5, factor 8, and factor 13. So it's involved in a lot of process. It's the most important thing. Okay, so then after you form thrombin, you can take fibrinogen and make fibrin, right? Fibrin is factor 1, and you make these polymers, this fibrin polymer, this kind of weaved network around the red blood cells. So this is considered a soft clot. From there, you can form this hard clot. Factor 13 comes in, which, like we said, is activated by thrombin and kind of makes it a stable hard clot. Not too important, but it's just another step, right? So once thrombin activates fibrin, you get this soft clot. Then factor 13 will come in and kind of tighten all the weak points, right, and make it stable. Okay, 13 activated by thrombin. So the point is, from a medication or a pharmaceutical standpoint, thrombin is a good place to try to, if you're trying to stop clot formation, if you need some sort of medication that's going to cause decreased bleeding, thrombin is a good place to try to work with. So yeah. And as I said earlier, these are going to be the tests you look for: prothrombin time, INR, or APTT, right? So a blood thinner, that's the word I was looking for. Thrombin is good for heparin. Heparin uses antithrombin, and it's a good blood thinner. I think we talk about that in a second. So these are a good slide to kind of sum everything up. So you could read that on your own. And then I guess y'all don't cover the drugs. Did y'all cover heparin and all that?
Yeah.
Y'all did? Okay. So I would know the drugs for sure. At least the ones y'all covered, because those are good testing points as well, and how they affect the lab values. I think we have to be going through that because we didn't talk about vitamin K yet. Okay, let's just go ahead. All right, so the formation, hematopoiesis, it's very important to know this process. So first you're going to divide. You're either going to be lymphoid or myeloid. Lymphoid is just going to be your T cells, B cells, and natural killer cells. This is just a brief introduction for y'all. Y'all have a whole course on immunology. So, but remember, myeloid, typically you think of red blood cells and maybe even platelets, but there's a lot of inflammatory mediators that go into that too. The granulocytes, granules, these are little things that are released from the cell that help with killing bacteria and whatnot. So you can see these granules here. And then you also have monocytes, which turn into macrophages once they get into tissue. Okay, so myeloid's going to divide here, and then you could divide further into different progenitor cells to the final blood cells. And then y'all will get into this a lot later, but B cells turn into plasma cells end up making antibodies. Okay, so just I think one of the main things is to be able to recognize these histologically. Because they will give you a picture. Eosinophils are bilobed. Basophils, you usually can't even see the nucleus because there's so many granules in there. Neutrophils usually are like have like 5 lobes to them, and then macrophages are just monsters. Megakaryocytes are even bigger, and the way the platelets form, they just bud off of this big megakaryocyte. And then obviously red blood cells, you have that central palate, that biconcave disc. And y'all really won't get into these too much, the lymphoid cells. So the process of forming blood cells originally as a fetus starts in the yolk sac, then you kind of convert it to the liver, and then finally as an adult or as you're growing, you start making blood in the bone marrow. So there's a couple of different factors that come into this. EPO is produced by the kidneys. If the body senses hypoxia, it can secrete EPO, erythropoietin, and that will cause the body, the bone marrow, to increase red blood cells. This is why a lot of people that are in chronic kidney failure, they can't make EPO, therefore they tend to be anemic, okay? Make sure that makes sense, right? So you're in kidney failure, you don't have EPO, you can't secrete this hormone, therefore you can't tell your body to make more red blood cells. So sometimes those patients, they can get exogenous or injections of EPO, and that'll help intrinsically raise their blood count. Thrombopoietin is going to cause increased platelets. Thrombo means platelets. And cytokines are going to be related to your lymphoid cells, okay? Cytokines are kind of tell the immune system what's going on and like what to do. So the thing you want to remember right now is that IL-7 is going to help to deal with the formation of lymphoid cells. And have a picture of that. Yeah. So anytime you have IL-7, you're going to tell that progenitor, we need more lymphoid cells. So go that way. So IL-7's there. All right. This is a big one. They like to test on this. This phase right here. So you start as a myeloblast, you go to a promyelocyte, then you get to a myelocyte. The myelocyte is the first phase where you can definitively say what that cell is going to turn into. Now, why is that? Because at the myelocyte phase, you get these specific granules. Now, the specific granules are specific to that cell type. So let me go back. You see these little granules here? These are all specific granules. Okay. So once the cell through this process forms a myelocyte right around here in the process, you can definitively say, I see specific granules, that is definitively going to turn into an eosinophil. Okay, so they like to ask about that. However they phrase it, you could say, at what point do you know it's a myelocyte? What is the factor that tells you what it's going to turn into? Those are the specific granules. Okay, so definitely know that. So again, make sure you can identify the cell types histologically. Those eosinophils, all that, whatever's in your small group, those would be good to know. All right, now, once you make that fibrin plug, after you've gone through the healing process, you've formed a scar or the wound is healed, you have to break down the clot, right? Oh, here's vitamin K. All right, good. So vitamin K is something that your gut bacteria actually makes. So this is why a good way to remember this is that when babies are born, they're given a vitamin K injection right after birth, okay? And that's because their gut is technically sterile at birth. They need a few days to kind of populate their gut so that they can actually make vitamin K. So that's how I remember that vitamin K is kind of made by the gut bacteria. And then it helps to deal with these factors. Some people like the mnemonic 1972. All right. So it deals with factor 10, 9, 7, and 2, or 2, 7, 9, and 10. So these are the factors that help with clotting. Remember, 7 is in the extrinsic pathway, 9 is in the intrinsic pathway, and then 10 and 2 are in the common pathway. Okay, so 1972, that's how you deal with that. That's how you know what factors are involved in vitamin K. So if they tell you that a child is born at home and there was no prenatal care or postnatal care after birth, and they say there's some sort of bleeding problem, know that the vitamin K isn't populated in the gut yet. So what the vitamin K actually does, this process, and a good word for you to know, is gamma carboxylation. Okay, this vitamin K is going to gamma carboxylate these proteins, and it's actually a coenzyme for it. So this gamma carboxylation is done by this enzyme here, gamma glutamyl carboxylase, and the process is called gamma carboxylation, and you need vitamin K to do it. Okay, so very importantly in our pathway, let's do this real quick though. In regards to these factors, if you have a vitamin K deficiency, what is going to be increased lab value wise? Yeah, we'll get to we'll do protein CNS in a second. Yes, right, both. They both have to be elevated, PT and APT, right? Because 7 is extrinsic, so PT is elevated. 9's intrinsic, so APTT is elevated. 10 and 2 are a common pathway. So point being, PT and APTT. Would you expect an increased bleeding time? Probably not, because your platelet, all the platelet factors are okay. Now, protein C and protein S are anticoagulants. Okay, so along with helping with these coagulant factors, there's a balance here because protein C and protein S are anticoagulants. So these come into play as well. So, and it gets a little complicated because these are actually inactivated first. So when you give something like warfarin, you actually get a state of heightened coagulation because these factors are still activated. This is more of a term 4 thing. But so you have to watch them. You have to leave them on heparin first for a little while until this goes through. Because you get these anticoagulants inactivated first, so the patients are hypercoagulable for about a week. So you leave them on heparin at the same time, but then after about a week, these factors will also be inhibited, and so they'll actually run out. So then the patient's on properly on warfarin long term, and warfarin's one of those drugs. If y'all remember those CYP450 enzymes. A lot of different enzymes break down warfarin. So these patients, they have to be monitored weekly or bi-weekly to check their blood levels because you don't want this to increase or decrease too far out of the therapeutic window because it could cause too much clotting or too little clotting. Okay, so that may be a little more advanced, but it kind of goes into the whole process of warfarin. Remember, this vitamin K epoxide reductase helps to recycle the vitamin K. So if you can't recycle it you use warfarin to inhibit the recycling, you can't have gamma carboxylation, and so you run out of these factors, okay? These activated factors. All right, so now there are some really strong drugs that you can use these for fibrinolysis to break down this clot. TPA is the big one they use. So Lindsey, do you remember the time frame? Is it 6 hours for TPA? What is the time frame? 4 hours.
It's
4
4
hours.
or 6. I don't remember.
3 to 4. That's right. It's 3
Yeah.
to 4. Okay. So if a patient comes in with a stroke, if they are within 3 to 4 hours, this does get a little complicated, but it helps to explain how this works. If they're within 3 to 4 hours, then you could actually give them TPA. It's a clot buster. That's what they call it. And so within that 3 to 4 hour window, the ischemic cells, or the cells that aren't really receiving a lot of oxygen, haven't really died off yet. So you could still use this clot buster and try to break the clot so that you get increased blood flow. Anything past that and you get something called reperfusion injury. But the point that you need to know now is that TPA is commonly used, that urokinase and streptokinase, that you could put them in the same category, but they usually talk about TPA. So anytime you can break down this fibrin clot. Now, what factor do you use to break it down? Well, you convert plasminogen to plasmin. So if we remember for fibrinogen, FGen to fibrin, you use factor 2, and then we'll form these fibrin clots. Now, if we want to break down these fibrin clots, we have plasminogen, and it is going to be converted to plasmin. and plasmin is going to come through and it is going to break down these fibrin clots. All right, so the point is that TPA can help to activate, and urokinase streptokinase can help to activate plasmin from plasminogen. So it can help to break down these fibrin clots. Does anybody know, I'm not positive y'all talked about this, when they talk about fibrin degradation, oh, it's right there, sorry. Y'all did talk about it. D-dimers, okay? So whenever you have to break down a lot of fibrin, these D-dimers are these products. So if you're looking to see if someone had, yeah, exactly, like a DVT, DIC, I don't know if y'all talked about that, but DVTs, sorry, it's really like the terms of like completely like mushed together. So I don't remember when we talked about stuff, but stuff like DVTs, right? You have this huge clot in your leg, and eventually it breaks down. This plasmin will come in, and it'll break it down. And once it's broken down, it'll form these D-dimers, and you can actually measure that. So if you think someone had recently had a DVT or deep vein thrombosis, meaning a big clot in their leg, if you think somebody has recently had one, you can check their D-dimer levels because these are the breakdown products of this clot. Okay. Yeah, good. So you can see that here, D-dimers will be elevated, DVTs, yeah. So, right, so pulmonary embolism, great example. It's not exactly a DVT, but it's a DVT that has broken off and gone to the lung. So remember, in the vein, the veins go back to the right heart, and then the right heart will send it to the lungs. So the lungs are very, the blood kind of, the vessels will get smaller in the lungs, and so that clot will get lodged in the lungs. Depending on the size of that pulmonary embolism, will determine, whether the patient makes it. Sometimes they die, they die spontaneously if it's big enough. But point being is, if you suspect pulmonary embolism or clots in the lung, check the D-dimer level. So that's a very testable point. All right, now, oh, here's the drugs, good. So anticoagulants, right? So heparin's a big one. And it's going to bind to and inhibit factor 10, factor 2, and some of the other ones. So it basically upregulates antithrombin 3. And so that is going to help to break down primarily thrombin. So if you don't have thrombin, remember that was that big component of making that proper, going through the coagulation cascade to the common pathway to making that fibrin clot. If you don't have thrombin, you can't activate fibrinogen to fibrin, right? So you can't make the fibrin clot, which is good for people that need to be on anticoagulants, people that are post-MI and stuff like that. Now, also protein C, as we talked about before, and S are anticoagulants as well. They're involved in that vitamin K pathway, that gamma carboxylation. So C is the main one, and S works with C. It's a cofactor. So they can inactivate factors 5 and factor 8. But the point you just need to know is that they're involved, they're anticoagulants, they're involved in vitamin K, and yeah, so gamma carboxylation. So drug-wise, remember heparin activates antithrombin 3, primarily will increase thrombin, so you can't make fibrin. Then remember, warfarin is going to basically block vitamin K, the use of vitamin K. Okay. Another good clinical example: if you have a warfarin overdose, you inject the patient with vitamin K, right? You try to offset the deficits. All right. So, and here we go. So aspirin irreversibly binds COX, so you get decrease in thromboxanes and platelets, depending on the dosage of it. But we're talking about blood and platelets, so we're typically talking about low dose right now. Heparin is going to activate antithrombin 3 and inactivates thrombin. Warfarin deals with vitamin K epoxide reductase, and then streptokinase is a plasminogen activator, so it kind of works similarly to TPA. If you activate plasminogen, you get plasmin, you can break down fibrin. You just have to talk through this stuff with yourself. Just sit there with it and just work it out, and you'll be good to go. Just a lot of terminology there. Now, super important, we've talked about this at length, bleeding time. Remember, we're talking about maybe Bernard-Soulier, thrombins, Glanzmann thrombasthenia, and even von Willebrand factor problem can be with that. So you're checking plasma count. Now, when you, if ristocetin, that's a good keyword, because if you are wanting to specifically identify von Willebrand's factor as a problem, this is the test you use. So far, remember we said we'll get an increased bleeding time and an increased APTT for von Willebrand. So you get this and you're like, okay, I definitely suspect von Willebrand's. Then you get a ristocetin assay, and that'll definitively say it. Now you can also, if you're trying to differentiate Bernard-Soulier or Glanzmann's thrombasthenia, you could do flow cytometry, check the GP, whatever they were, 1 or 2B3A thing, and you could definitively figure that out. I suppose, I don't know the treatment for that. You probably could give those exogenously, the 1B3A or whatnot, and fix that. So good to know. Make sure you can differentiate these on the test. And right, so let's say this is a good example here. We have increased bleeding time. Patient comes in, they cut themselves, they haven't stopped bleeding for a couple of hours, they're wondering what's wrong. What do? First thing, you check the platelets. If you have low platelets, easy, thrombocytopenia, you have a low platelet count. If you have normal platelets, that means everything's there. It's a qualitative problem, not a quantitative problem. This means it's quantitative, you don't have enough platelets. This means it's qualitative, right? So you have something wrong with the platelet formation. So 1B, Bernard-Soulier, 2B3A, Glanzmann. So do that flow cytometry and you could figure that out definitively. All right, and then we talked about these problems forming that secondary plug, or excuse me, the secondary clotting pathway, the coagulation cascade. Remember, hemophilia A is factor 8, hemophilia B is factor 9, and then we discussed the platelet plug problems, right? Thrombocytopenia, you'll have low platelets. Bernard's and Glanzmann's, you'll have normal platelets, but there'll be a deficiency in those factors. All right. Oh, and look, here's some good examples of it. Increased bruising, bleeding into the joints. That's classic for hemophilia. Epistaxis, nosebleeds that won't go away. Okay, so you're thinking increased bleeding time. Now, hemophilia A and B, you can see that here. Obviously, the main thing to know here, intrinsic pathway. So both will cause an increase in APTT. Okay, important slide here, differentiating. Remember, if it's extrinsic, it'll probably be factor 7. If it's intrinsic, it'll probably be one of the hemophilias, bleeding into the joints. Okay, and von Willebrand's, remember, increased bleeding time and increased APTT. Now, that is all I got. What time did we start? How long?
Do we want a 5-minute break?
Probably should take a break. Yeah, we'll take a break, guys. Let's do it.
Yes.
All right. Well, I guess. All right.
Okay, Brady, I'm gonna ask for control of your computer.
I approve you. Don't
Yeah.
go to my DMs. Kidding.
Oh my goodness. Okay, so let's try this question, guys. Brady. Okay, well, you guys already saw this because he was clicking through. So this is exudate with neutrophils as the main component. Now, what in here tells us that this is the answer? So 3-day history of sore throat, swollen, painful lymph nodes, febrile. Oh, oropharynx shown below. That's why you were clicking through, because we don't have the pictures here. Okay, so apologize for that. There's a picture after this one. So inflammation. The biggest thing is you need to be able to tell between acute and chronic, and then under the umbrella of chronic, you need to be able to tell, you know, granulomatous versus non-granulomatous. So acute, the biggest thing is neutrophils. Neutrophils are the immune cell that signal acute inflammation. These are the cells that are going to, they're one of the first ones that go to the site of infection, inflammation, any sort of injurious agent in an area. Neutrophils are the ones that get there first, one of the ones that get there first. So if you have a question talking about an abscess, a draining abscess or anything like that, the answer is neutrophils, because they're probably going to ask you what cellular component are you going to see. Answer is neutrophils. Versus chronic, which is macrophages, lymphocytes, plasma cells. All of these cells come a little bit later. For your purposes right now, the biggest thing or acute is neutrophils. I don't remember them harping on the chronic immune cells in term 1, but just understand that neutrophils are acute, everything else is going to be chronic. So that's the biggest thing for acute. So again, I said, are you doing that or am I doing that? I don't know what's going on.
I quit. My bad. Sorry, hands off. I quit. I was trying to do something else. Mother.
Touching. Okay, wait. How do I go? Can you go back? I don't think I can go back on your computer. I can only go forward. Okay. Thank you. Okay, now I'm controlling it. Sorry, guys. Sit on your hands, Brady. Okay, so acute, like I said, neutrophils. The definition is suppurative or purulent, kind of interchangeable terms, pus containing, exudate. Basically, this entire left side of the screen is probably going to be maybe 1 or 2 questions. The biggest thing is just neutrophils. Again, like I said, it's one of the first immune cells that arrives in this place. And so that's how you know it's neutrophil. So if you take a biopsy of the area and you see neutrophils, you know there is an active acute inflammation there. Another thing that is good to know, typical bacteria that you can see are these pyogenic bacteria. Pyo meaning pyo is like fire, but it's heat, warmth, but it causes purulent infection. So staph and strep, such as S. pyogenes and S. pneumoniae. Not the biggest high yield point here, but you should be able to recognize this. This picture at the bottom is actually the picture that I was trying to show in the question. But if you might see a picture like this, but you can see these white areas, these white pustules. And so these are tiny areas of inflammation. And if you took a scraping of that, if you looked at that, you could see neutrophilic infiltrate in that area, showing you that it is an acute active infection right there. So that's mostly acute. Now, if you look at this, we're still looking at acute. So suppurative versus fibrinous. Now, if you look at this left one, all of the blue, those are all neutrophils because remember, neutrophils have those multilobular nuclei, and they stain very basophilic. And so you can see in here, there are many, many, many neutrophils in here. So you have a high neutrophilic infiltration in this area, meaning you have a suppurative acute inflammation versus the fibrinous. So you see a bunch of fibrin in here and very few neutrophils. You can still see the neutrophils with the very basophilic nuclei, but it's much less than our purulent, suppurative. Purulent and suppurative, remember, those are a little bit interchangeable. Acute inflammation. Just remember neutrophils, write that like 10 times on your page. Now we're going into chronic inflammation. I just put the granulomatous information on here because this is a big one, and non-granulomatous is essentially the absence of these granulomas. So this is a distinct pattern of chronic inflammation. Essentially what your body is doing, it's kind of walling off inflammation. This is what it's doing. It's trying to get rid of this thing. It's trying to get rid of this thing. It can't get rid of it. And so what these immune cells do is they essentially form a granuloma, this patch of cells around this object. And so you can see foreign body versus Langhans cells. Don't get this mixed up with Langerhans cells. Please note the spelling of it, because they could put both spellings in the answer choices, and you have to know that it is Langhans cells. So note that there, the foreign body cells on the left, you can see this is surrounding a non-immunological agent. So basically this is more like if you get a foreign body inside, so a splinter or a piece of glass or something that's not native, versus the Langhans cells. This is going to come back a lot in term 3 and 4. But for now, just recognize that it is a Langhans cell, recognize the spelling of the Langhans cell so you don't get it mixed up with another type of cell. But this is going to be like very characteristic in tuberculosis, sarcoidosis, leprosy. So any like immunologic agent, biologic agent that your body is trying to fight off, it can't get rid of. So it basically walls it off and it blocks it off. And what you're seeing is the accumulation of activated immune cells in this area. So know the difference between these two. Know the difference. If they describe it, you need to be able to say this is chronic granulomatous inflammation versus chronic non-granulomatous inflammation. But remember, as long as they give you the description of these activated immune cells in the area, you're talking about granulomatous inflammation. Okay, so that was basically the big stuff you need to know with inflammation. Gonna go over again, PPP, pentose phosphate pathway, and G6PD deficiency. Again, so pentose phosphate pathway, this is just another name, hexose monophosphate shunt. You'll go a little more into this in term 2. What you need to know here, it's at the beginning of glycolysis. This is kind of an extra pathway off to the side, honestly. And so it occurs in the cytosol in the cell because it occurs right next to glycolysis. So glycolysis is in the cytosol. This occurs like right by glycolysis. So cytosol in the cell. It's an alternate pathway for metabolism, and then it provides NADPH. This is the kicker of the pentose phosphate pathway. This is why it exists, to provide NADPH. So if this is its function, this is why we have it, and this is very high yield. Brady.
I messed up real bad, Lindsay. Hold on. People that are messaging me, I can't talk to you, right? I can't.
I mean, if you want to control the screen, you can, but
no, thank you. Where were you? Right up in here somewhere. Here we go. Right here. All right, sorry. I'm in timeout. Let me mute myself. Come on. All right. Uh-oh, shoot.
You're good. This was the next slide, right? Sorry, guys. Okay, where is it active? So liver, lactating mammary, adipose tissue. The biggest thing is erythrocytes, because remember, your erythrocytes, these are non-dividing cells, and they only last for a certain amount of time. And so if you have a defect in this pathway, you are going to see the presentation of that, because you're going to have a depletion of something. So erythrocytes, so you need NADPH for the reduction of glutathione, and then white blood cells, macrophages, kind of the same thing. The biggest thing, red blood cells, erythrocytes. That's what you want to hone in on for that. Uses of NADPH from the pentose phosphate pathway: reduction and detoxification of hydrogen peroxide. This is important in the red blood cells, and then phagocytosis in the white blood cells. This is the respiratory burst test. Brady mentioned it before. This is extremely high yield. You need to know the difference between negative and positive respiratory burst tests and which enzymes are associated with each. And there's a disease associated with each. So you need to be able to go through all of that. But biggest thing, so this is just going over the respiratory burst test. So the two enzymes you need to know: hypochlorous. Yeah, hold on, I have it up. Yeah, hypochlorous acid, and then the superoxide dismutase. Oh, come on. There we go. Okay, do this one real quick. Myeloperoxidase, that's what I was trying to say. All these enzymes are running together now. Brady's in timeout, so message me with your answer. So you actually got a huge clue here, or not clue. I diagnosed the patient for you. Chronic granulomatous disease. Oh yeah, we're gonna say D is supposed to be negative. Thank you for keying me in on that. So the answer is NADPH oxidase deficiency, which will give you a negative respiratory test. So you need to understand that chronic granulomatous disease is associated with the NADPH oxidase. That's really hard to say fast. Deficiency, which is associated with the negative respiratory test, versus myeloperoxidase. If you have that deficiency, it's going to be a normal or a positive. Again, fungal infections, this is what you're at risk for. The biggest thing, please know the enzyme deficiency is associated if it has a disease, and then you need to know the respiratory burst tests, positive versus negative. This will get you like maybe 2-ish points on the exam. PNA is pneumonia. You guys are getting it right. Now, what is the predisposing factor? Because this kid has something that tells you he was predisposed to essentially an attack of his disease. What keys you in on that? We talked about fava beans, sulfa drug, exactly, sulfamethoxazole. This is a sulfa drug, and this will predispose this patient to essentially an attack or an exacerbation of the disease. So biggest things you need to know is a G6PD deficiency. It's X recessive, leads to hemolysis. You're going to see Heinz bodies, red blood cells, status post infections, oxidant drugs, sulfa and fava beans, and then allelic heterogeneity. I'm pretty sure they tested this pretty heavily on the exam. And so in the vignette, they're always going to say something about sulfa drugs or fava beans. Always. And then of course the clinical presentation, but you're going to have a kid that ate fava beans or had an infection and then took an antibiotic like this. Hypertension and heart failure. This is kind of a daunting lecture that has a few big overarching concepts, but the testable information is actually pretty little at this point. And so we're going to go over this. I'm going to explain the concepts. We actually just did, and then I actually took the completion exam on this. So last time when we were actually in the review and I had to study for completion, I was going over this stuff. So huge, daunting, overarching lecture, but I promise you it's not as bad when you understand it. So biggest things to keep in mind are the factors that are changed or can cause change. So these can be incorporated into a number of objectives. So do this question real quick. Okay, I'm going to give you about 5 more seconds. Okay, so the answer is vascular smooth muscle hypertrophy, and I'm going to explain this. So pathogenesis of essential hypertension, don't really know. Could be genetic, could be multifactorial, but there are defects in blood pressure regulation interacting with environmental stressors. So just concept, mean arterial pressure is cardiac output times total peripheral resistance is how you're getting the blood pressure. Remember MAP, I don't remember the long one, it's like 1/3, 2/3, I don't know, but you need to know that. But essentially, primary pathology, you have an increase in total peripheral TPR or increased cardiac output and or increased blood volume. You'll have the your heart will start pumping harder, preload and afterload, and then you have a lot of changes afterwards. But pathogenesis, pump-based hypertension, so you do have an increased cardiac output, increased TPR, increased retention of sodium and water. So this relates to increased blood volume. So increased blood volume is going to increase your blood pressure simply because there's more to pump around in the heart. So know these arrow directions: increased CO, increased TPR, increased retention of sodium and water. Please know the directions of the arrows and all of these things, but these are just 3 different pathogenesis explanations, hypotheses for essential hypertension. So again, you have a bunch of things that can lead to hypertension, exaggerated responses, increased sympathetic outflow, which is going to increase the heart rate and everything. And then you have also reversible hypertension, vascular smooth muscle hypertrophy. So if you have smooth muscle hypertrophy, you are going to increase your blood pressure by nature because you are you're increasing the afterload, increasing the pressure you have to push against, and so you are going to get hypertension. But smooth muscle hypertrophy leads to vasoconstriction simply because you have a decreased lumen, and then chronic increased TPR, which can lead to it. Yeah, this slide is actually pretty convoluted, I'm not gonna lie, but I've highlighted the things that you need to focus on. Essentially, the 2 things that I've focused on here are the vascular hypertrophy and then vasoconstriction, leading to vasoconstriction. This concept is big in renal because you're going to go over the renin, angiotensin, aldosterone system pathway, but we introduce it here. So salt imbalance, this is the renal hypothesis, is volume based. So if you have low sodium, that equates to low blood volume and low blood pressure. And so if there is a discrepancy between sodium intake and excretion, you can effectively change your blood volume. So when it says increase ECF, that's what it means. It's talking about blood volume. So this is saying it's the increased blood volume, plasma volume, CVP, venous return, stroke volume, and blood pressure. So this is why you're getting an increase in blood pressure due to an increase in blood volume. And then, of course, if you have the hypertension, you get vascular smooth muscle hypertrophy, and then vasoconstriction, which is going to lead to an increased TPR. And then just role of baroreceptors, they can modulate changes that I don't remember how big that was in term 1, but just understand that the baroreceptors can change the heart rate and if you have a change in blood pressure, you're going to sense it in the baroreceptors, and they're going to decrease the heart rate to compensate for the increase in blood pressure. So that's what it's talking about there. Why are we worried about hypertension? Because any compensatory action is going to be bad over time. So you know the phrase, too much of a good thing is a bad thing. That's exactly what happens here. So if you increase the workload of the left ventricle because you are getting that hypertrophy from years and years of uncontrolled hypertension, then you can get cardiac failure. And so, you have the hypertension over and over and over. You're getting the smooth muscle hypertrophy to accommodate for the increased pressure of the heart. And then over time, you get the constriction because you're really just narrowing that lumen, and then the blood pressure gets worse, you get more hypertrophy, including the left ventricle, so it's good because it's protecting the heart, you have increased pressure, so you need to protect yourself against that pressure. But guess what? Over the time, you get too much hypertrophy, you get too much workload. Oh, guess what? Now you're in cardiac failure because your heart has compensated so long and so much that it can no longer work correctly. It can no longer pump out blood effectively. And this is what this is talking about. Increased workload of the left ventricle. It's due to the left ventricular hypertrophy from the sustained hypertension over years and years and years. It can no longer pump blood out. You get congestive heart failure. So congestive heart failure, talking about it, backing up into the lungs. You're getting the pulmonary edema, which we're going to talk about in a sec. And so essentially this is why they call hypertension the silent killer, and this is why a lot of people are non-compliant with their meds because they can't feel the effects. But hypertension is devastating on the body because everything's trying to compensate for that increased pressure, so it's thickening and thickening and thickening. It's like, okay, if you're going to keep punching me, I'm going to get stronger and stronger and stronger, but over time that's actually a really bad thing. So that's why you're getting that. And then of course increased risk of vascular disorders. That's exactly what it ties into that the thickening of the walls. You're decreasing compliance because it can't snap back. And so you can get hemorrhages and aneurysms because if you're thickening up and you're not complying with the pressure, you can get aneurysms just because you're weak at that point. Deposition of proteins, loss of nephrons. So this is renal damage. A very, very, very common complication down the road of uncontrolled hypertension is renal damage. And then increased risk of developing an atheroma. It's not the highest yield thing for you in term 1 right now, but yeah. So we have systolic heart failure. So we're talking about the left side of the heart that's actually pumping out. Like I was, went on my little tangent on the last slide. If you if you have uncontrolled hypertension and your heart and vessels have to compensate for that continuous like punching over and over and over again, it's like, okay, I have to toughen up. Well, guess what? Now you can't do it anymore. Systolic heart fractures failure. So the best way to monitor this is your ejection fraction, because the left heart, of course, is responsible for the ejection of blood to the rest of the body. So if your left ventricle is hypertrophied so much that it can no longer pump out the required blood to support your body, you have systolic heart failure. And so how are you going to do test that? It's the ejection fraction. So ejection fraction is stroke volume over end diastolic volume. That makes sense because stroke volume is what's going out and diastolic volume is what stays in. And so you can figure out how much blood the left ventricle is pumping out. Again, the worse the left ventricle has compensated over time, hypertrophied over time, it's not going to pump that much blood out. And so you get that heart failure. Okay, heart failure, systolic versus diastolic. Big thing here, you need to know ejection fraction is going to be low in systolic. Makes sense because that's the pumping of the heart to the rest of the body, versus diastolic. This is going to have a normal ejection fraction. Why? Because heart failure with I can't talk. You're going to have a preserved ejection fraction with diastolic heart failure, because you're going to have both a reduced end diastolic volume and a reduced stroke volume. So, and then the Frank-Starling curve shifts down and to the right. This is super important on those curves. Come on, here we go.
Let me say something. I was trying to press the button. Look, so yeah, wait, this. So this comes into play a lot later, but this is important for you to know. When you think about these heart failures, systolic heart failure is an ejection problem, right? Systole is ejection. So why would you have a problem with ejection? Well, typically the heart gets dilated. So you get dilated heart failure. And when the heart's dilated, the walls get floppy. So you don't have proper muscles to compress, right? So that's why you have a problem ejecting. With diastolic heart failure, that's a problem filling. Why do you have a problem filling? That's because the muscle got too thick, okay? So the area that you could fill, the ventricle, is smaller. Now, because the area of filling the ventricle is smaller, your ejection fraction stays the same. So you're still ejecting less volume, but so you're still going to eject the same. The ejection fraction is the same, say 50%, right? 50% of what's in the ventricle. But remember, because you're in diastolic heart failure, you can't fill properly. Okay, so you might be ejecting 50%, but it's 50% of a lower volume. So that's the difference. Systolic heart failure is a dilated heart failure. Diastolic is a filling problem. Okay, that's as far as y'all need to go for now. I'm sorry, Lindsay, I'll leave you alone. Here you go.
Thank you, Brady. You can chime in, just don't go 3 slides ahead. Okay. So conditions that cause left ventricular failure, you do need to understand these. I circled these things in green. These are, remember that slide I put at the front, pay attention to the factors that can change, affect certain things. That's what you need to pay attention here. So decreased contractility, decreased stroke volume here, increasing afterload, stroke volume is low, EDV is normal, EF is low. So understand these things. We've kind of talked about these things. So I just wanted to point out that you need to memorize the direction of these arrows, because they could put one of those big charts, and then you have the columns, and then like up arrows, down arrows, normal. That is fair game here. And that's also something that was very, very big on this exam, knowing what was increased, knowing what was decreased, depending on what was going on in the body. So, okay, pressure volume loops. We've talked about these before. This, please look at these, please understand these. Systolic failure. This makes sense, right? Because if you have impaired contractility, you are going to have increased EBV. And so you see that here on the bottom, you have a very big increase in the end diastolic volume. So you see that this actually, this curve kind of looks normal right here. It's just shifted really far to the right with the end diastolic volume. But you have, of course, increased EDV, reduced ejection fraction, because your stroke volume is going to be affected too. Increased blood volume, RAS. Again, that you get a lot into this, and then in CPR too with renal. Wall stress, work for the heart. We talked about this. And then diastolic, you see this decreased compliance here. You have increased end diastolic pressure, reduced filling, normal ejection fraction, reduced stroke volume. So know what it looks like here. And then, of course, systolic and diastolic failure. You're most often going to have both in heart failure, because if one aspect of the heart is failing, the others are going to try to compensate, and then over time that's going to fail as well. So you're very often going to see both systolic and diastolic failure. And then, left heart failure, right heart failure, they're probably going to be together. Some consequences: pulmonary edema. This you're going to see in left heart failure mostly, and then right heart failure is going to give you peripheral edema. I mean, it makes sense, right? Because if you have a part of the heart that is failing, then everything behind it is going to get backed up. And so if the left heart fails, you're going to fluid is going to back up into the lungs, because you have the increased pressure. You have the increased oh my God, osmotic pressure, my God, pushing fluid out into the lungs. Same with peripheral edema. You have the increased pressure backing up because it can't get into the heart. If you have that increased pressure there, then it promotes leakage of fluid into the interstitial area. But again, you are probably going to see both of these, because if you have left ventricular failure, if you have left heart failure, it's going to cause right heart failure, because if you back up into the lungs, then you're going to back up into right heart, and then you're going to back up into the systemic system. So you're a lot of times you are going to see both pulmonary edema and peripheral edema in a patient. I circled some things here again that I just want you guys to focus on: reduced cardiac output, vasoconstriction, sodium and water retention, sympathetic mediation, endothelin and ANP were, I remember being on this exam, and then less compliant. You'll notice that I just highlighted the terms that I want you to, they're like the up and down arrow terms that are associated with it. So you need to understand what is increased, what is decreased, all of that stuff. And then effects of cardiac failure on venous return and cardiac output. I would know where these lines are going. So A to B, and then what happens C to D to E. So you do need to understand what's going on here. So you have this normal heart right here. This is an A. And then something happens, and then you have to go to B. So what's going on here? Someone want to try to explain it? You know it's the failing heart, but why did we shift from A to B? Yeah. Yeah, you can unmute yourself if you want, because I'm getting a lot of answers here.
It's like because of decrease in contractility, right? So that's the curve.
Yeah, you have the failing heart. So you're trying to if your heart is failing, you're going to try to increase sympathetic activity. And so this is just like varying degrees of that right here. So you just have a decrease in that. So that's what you're seeing here. Central venous pressure. Yeah, cardiac output. So some of these graphs, honestly, you can memorize the points on them because they are high yield points that they want you to understand. And so a lot of these, you can actually memorize these points on here because some of these graphs are very, very, very confusing. Like I spent so much time with tutors just going over these graphs and sitting here looking at the different points. And I understood it fairly well, but my biggest, if you are getting to the point where it's not sticking in your head, memorize some of these points and what's happening, and try to get away from it conceptually and just, okay, this point means this point means this point means this, and it's okay if I don't understand why it means this, but for the exam purposes, if you can't conceptually get it right now, just understand that this means this means this means this, because I've had a few questions about that. And then continued activation of compensatory mechanisms. I talked about this. Too much of a good thing is a bad thing, because all of these compensatory mechanisms to correct heart failure are not good. If you increase blood volume, yeah, that'll increase your blood pressure. That'll bring you back to normal for a while. But guess what? Over time, you're going to get pulmonary edema, because increased blood volume, you can increase the pressure and you increase the forces on the walls, and you can get that pulmonary edema. Increase TPR, you can increase afterload, which means you're going to decrease stroke volume and cardiac output concurrently. Increase heart rate, you increase metabolic demand because you're just working harder. If you all of these things, this is trying to help you in the short term, but in the long term, too much of a good thing is a bad thing. And it's actually going to decompensate you, because your compensatory mechanisms are now hurting you. So now you can go into decompensated heart failure.
Lindsey, I had a question real quick. Can we go back one?
Yeah.
Yeah, so, right. So you're going into heart failure, right? So the left heart is failing. So how do you compensate for the left heart not contracting or failing? You have to get more blood to from the right heart. From the venous system to the right heart. So yes, for your question, you will increase your central venous pressure. The central venous pressure is analogous to your right atrial pressure. So that makes sense, right? The venous pressure, if you increase the venous pressure, you're shrinking down those pools, that excess blood in the venous system. Therefore, the only way that the blood could go is back to the heart. So by venoconstricting, constricting those veins, you're causing excess blood to go back to the heart. And that's going to help to compensate for the fact that the left heart isn't contracting hard enough. So you can't contract hard enough, bring more blood back in. And that's what's going to cause the blood to go back. That's what's going to cause your increased central venous pressure. And yes, venoconstriction is right. You're shrinking down so remember, the veins are going to they're going to keep excess blood there, a reserve volume. So venoconstricting will shrink down that reserve volume. Only way for the blood to go is back up to the heart. Okay.
I'm going to go back real quick because I had some requests to go over what these points mean. So I think I can, yeah. So you have the normal heart rate here. So if you have a failure, of course, you're getting the decrease in cardiac output. And so this is uncompensated right here. This line, this circle that I have drawn, this is uncompensated because you have an initial decrease in cardiac output because you're having failure, but you're still at the normal sympathetic activity because you haven't compensated yet. Now, when you start to compensate, look here, you have this increase in sympathetic activity because you're trying to increase the venous tone. You're trying to do all these compensatory mechanisms so that you can maintain the cardiac output. So look here, from B to C, you're increasing that cardiac output because a decrease in cardiac output is bad. So to increase that cardiac output, you are increasing the sympathetic activity. So this is going to bring you up to C. Now you see C to D to E. This is actually you're kind of staying at the same cardiac output. All you're really doing is affecting the sympathetic activity. And then you can see you get, if you're increasing the venous tone, then you're getting some fluid retention. So this is, you're still compensating. Fluid retention is at the level of the kidney. You are increasing sodium and water retention to increase that blood volume. And so that's what fluid retention is. That's the RAS system kicking in, that's increasing compensation. And then you get increasing compensation because you're just increasing fluid retention. And so hopefully you're getting back to that normal sympathetic activity. So what you saw here is that initial heart, so you're not compensated yet, B to C, and then to D to E, you're compensating. And now you're kind of at this level where you're at the normal cardiac output, you're sustaining that normal cardiac output, and you're sustaining the normal sympathetic activity. But look at the cost. You have this increased chronic fluid retention. And this right here, this compensated heart failure right here, even though your heart is working relatively at, you have a pretty good cardiac output, look at what you are affecting right here. You have this increased fluid retention, and this increased fluid retention is what is going to, over time, cause the pulmonary edema. It's going to cause the peripheral edema. Did that make sense? I didn't explain it last time. Sorry.
Yeah, so
Awesome.
think about it over time. As the heart fails further, you're going to move from C to D to E. And like Lindsey was saying, there are consequences to holding on to all that extra fluid. The heart's not pumping. It's like, we'll hold on to more fluid then. It's pumping less, it's contracting less. We'll hold on to more fluid. It's pumping less. So you get to the point where E, and you're like, we're holding on to all this extra fluid because you could barely contract the heart. And eventually you get to a point where you get to decompensated heart failure. You can't, the right heart can't compensate. So yeah, but look at the consequence. You can see the consequence going from C to D to E by looking at the central venous pressure. You're constantly increasing that, right? As you get worse and worse.
For fluid retention, they can ask you pulmonary edema and peripheral edema. They'll probably ask you that. Hemorrhagic shock. I didn't put any slides here. We just have a question. And then I'm going to use this question to make my point. WNL is within normal limits. A lot of you guys are getting this. So we have nausea, vomiting, diarrhea. So we're having a fluid loss here, right? And so if we have an increased fluid loss, we are going to have hypovolemic shock. Now, hypovolemic shock can happen due to hemorrhage. It's anything that's going to cause the blood volume to go down. And nausea, vomiting, diarrhea can be one of those things because you get to severe dehydration. You can see that he is very hypotensive here, 102/60. And you can also see that the heart is trying to compensate for this low blood volume by increasing the heart rate. So this is good. This is going to be because of the baroreceptor activity, the sympathetic activity, increasing the sympathetic activity on the heart so that you can maintain that cardiac output, even though you do have that hypovolemia. So the biggest things here, I didn't put anything extra on here. Honestly, there are maybe 2 questions on this, but it's just knowing the types of shock and how to recognize that. Cardiogenic would be like a failure of the heart. So anything that it directly affects the heart's ability. Obstructive shock would be probably, I think it's PE, like a DVT or PE. Septic, of course, if you have severe septicemia, you have a lot of things that go on into that because you have direct injury because of the organisms in the blood. And then, of course, neurogenic shock, if you the heart is under sympathetic control, remember, because you can change it. And then you can, if you have neurogenic shock, you can actually affect the ability of the heart to work.
Lindsey, let me just clarify this. So typically any sort of fecal oral route, so the drinking from a natural lake is going to cause, like Giardia is common. That's why you have to boil lake water. Those are typically enteric bacteria, so they're going to cause diarrhea. So the hypovolemia is secondary to the diarrhea and the vomiting. Septic would be more of a bloodborne pathogen, so something that would get into your blood. You wouldn't necessarily want to jump. Septic would be a secondary answer, but because of the 3-day history of diarrhea, you're probably going to have hypovolemia. And just, y'all haven't really learned this yet, but these drugs that you tend to ingest, they tend to stay in your GI tract, not really get into the blood too much.
Yeah, this would be just a GI limited infection versus a an actual bloodborne illness. Like they're limited to the GI system. They're very few of them are actually going to be invasive.
Y'all will spend 3 to 4 weeks going through the gamut of diarrhea. So if y'all have problems, we know everything there is to know about diarrhea. Y'all just let us know. Y'all email Lindsey and she'll diagnose you.
Well, and I don't know if you guys have gone over this before. It's probably in CPR too. You're going to go over volume expansion and contraction, and diarrhea, not vomiting and diarrhea is one of those things that can cause a volume contraction. So
yeah,
you'll get all of that, get into all, I can't talk today, guys, I'm sorry. Get into all of that with renal, because that goes into maintaining blood volume. And we talked a little bit about this, and I mentioned the RAS system in the renal, but which is why on that slide, it takes time to compensate and do the fluid retention at the level of the kidney. So you guys we're going to get into all of that fun in CPR 2. And
then the question, so hypovolemia doesn't necessarily mean it's GI. You can also get that commonly in trauma too. So if you have some sort of trauma and you have a lot of blood loss, but
anything
when we talk about
that causes fluid loss.
Yeah.
Anything that causes fluid loss.
Hey, all right, good. Well, good luck on your exam Wednesday. Have a good weekend. We will celebrate 4th of July for you guys, and that'll be great. I'll see y'all on the island soon. Y'all are almost there after this exam. There's almost a light at the end of the tunnel.
Almost.
So,
oh, you'll be happy to know that I did very well on my completion exam and I survived term 4. So,
yeah.
I don't know.
All
maybe
right,
you're
guys.
happy.
The anatomy exam, we could talk about that in the next CPR2 thing, but we have some pointers for y'all to go through. Kishore probably knows better than us because he took that. We didn't actually have to take it.
Yeah, we didn't take the term 1 OSCE or the anatomy exam because they were figuring out how to do everything online.
We were shipped home during MSK.
He went home. I didn't go home. I was
Oh,
brave.
well,
I was
yeah.
brave.
You were brave. Okay. Yeah, so we were shipped home. Well, whatever. Because of COVID. So we didn't take that exam, but we'll make sure Kishore updates y'all on what his pointers were for the lab exam and the OSCE, but don't worry about that right now. Y'all can cross that bridge when you get there. So anyway, good luck. I'm gonna stop the recording. If y'all have any extra questions, we'll stay back.